You ever feel like you're just drowning in information? Like you've got all these reports, these studies, and you just wish someone could point out what really matter.
Oh, absolutely. It's that feeling of needing a shortcut through the noise.
Exactly. And that's what we try to do here on the deep dive. Cut through that clutter, bring some clarity, and maybe point out a few surprising things along the way.
Definitely.
So today we're doing a deep dive into something I think is really fascinating. Hospital patient mobility. We're looking at this program, STRIDE, which has been pretty successful.
Right, stride.
And its story kind of challenges what we think makes new health programs actually stick, in the real messy world of healthcare.
It really does. And our mission today basically is to unpack the specific things about the hospitals themselves.
Yeah.
The organizational stuff that seem to predict whether they'd actually get this STRIDE mobility program up and running. We're using a big study from the Veterans Affairs System, the VA, largest integrated system in the U.S. So we'll look at what factors really seem to matter for adoption. And yeah, like you said, some of it might surprise you.
Okay, so let's start with the why. Why is patient mobility in hospitals even such a big deal? What's the problem STRIDE is trying to fix?
Well, the core problem is what they call hospital-associated inactivity. And it sounds maybe minor, but it's really not.
Okay.
It causes some really serious negative outcomes for patients. We're talking increased risk of delirium, more falls,
Falls are huge, yeah.
huge, and longer hospital stays, which nobody wants. Plus, a higher chance of being readmitted after they go home, and just a general decline in their ability to function. It's a whole cascade.
Wow, okay. So it's not just about feeling a bit stiff then.
Not at all.
So enter STRIDE. What exactly is it? You mentioned mobility.
Right. STRIDE stands for Assisted Early Mobility for Hospitalized Veterans. Catchy acronym.
Ah, yeah.
But the idea is pretty simple. It's an evidence-based approach to get patients, usually those 60 and older who can walk safely, moving early and often, ideally within the first 24 hours of admission.
So like supervised walks.
Exactly. Supervised walks, it involves a specific assessment first, looking at their gait and balance, and then daily supervised walks based on that.
Seems straightforward enough, and you said it's effective.
Very. It's been shown to be associated with lower rates of patients needing to go to a skilled nursing facility after the hospital. That's a big deal for independence and for costs.
Yeah, absolutely.
But what's maybe even more impressive is how it spread. It started as a single trial in one VA hospital, Durham VAMC.
Okay.
And by late 2023, it was successfully implemented in 41 VA facilities, with another 17 getting started.
Yeah.
That's pretty remarkable scale up.
Okay, now that's interesting, because you hear all the time how hard it is to get proven things actually used in practice.
Exactly. That kind of success is genuinely rare. Most evidence-based programs, they just don't make that jump from the research paper to the bedside.
What are the numbers on that? Like, how many fail?
The estimates vary wildly, but some say anywhere from 30% up to maybe even 90% of efforts to implement these proven practices just fizzle out. They fail.
90%. Wow.
Yeah. So STRIDE really stands out. And it makes you think, okay, how did they do it? It strongly suggests that understanding the context in the hospital environment itself must have been critical.
Right. So the researchers didn't just look at if STRIDE worked, but where and why it got adopted. How did they actually investigate that? How did they measure context?
They used what's called a parallel mixed method design. Fancy term, but it just means they combine quantitative stuff surveys, administrative data, the hard numbers, with qualitative insights from interviews, getting both the what and the why.
Okay, makes sense. Numbers and stories.
Exactly. And they did this across the VA system. And they focused on specific organizational characteristics.
Like what? What were they measuring?
Well, facility complexity. And that's not just size. It's about patient volume, patient risk, if they're involved in teaching or research, how many different doctor specialties they have. Interestingly, a lower score, like 1A, actually means higher complexity. Yeah, big counterintuitive.
Okay, got it. More complex gets a lower score. What else?
Material support or resources. Basically, did the hospital get specific money or staff assigned to STRIDE? Crucial question. Also, their experience with implementing evidence-based practices, EBPs. Had they done this kind of thing successfully before?
Practice makes perfect, maybe.
Potentially. They also looked at softer things, like organizational resilience, how well the place adapts to challenges, and organizational readiness to implement change, basically. How committed they were and how confident they felt about making changes.
Okay, the mindset stuff.
Right. And implementation climate, things like focus, training support, recognition for doing the new practice. Plus, they threw in some standard hospital metrics like adjusted length of stay and patient satisfaction scores.
That's quite a list. So with all those factors potentially playing a role, how did they define success? What did it mean for a hospital to have adopted stride?
They set a pretty practical benchmark. Adoption meant the hospital completed supervised walks with at least 5 unique patients during the 5th and 6th months after they officially launched Stride. And this was with minimal handholding from the central support team.
Okay, so 5 patients in months 5 and 6. That shows it's actually happening, not just planned.
Exactly. It's a threshold for minimal sustained activity.
Wow.
Proof that the program was really underway.
Yeah. Drum roll. With that benchmark, how many hospitals actually hit it? What was the adoption rate?
Yeah, this is where it gets sobering. Only 31% of the hospitals actually met that benchmark.
Only 31%. Wow. Even for a program with proven benefits and this level of system support.
Yep, just under a third, which tells you right away, even with a good intervention, successful implementation across many sites is really, really tough.
So that makes the question even more critical. What separated that 31%? What really drove adoption, according to their data?
Okay, so looking at the quantitative findings of the numbers, a few things really jump out. First, that facility complexity measure we talked about. Huge impact.
How so?
Only about 7%, of the most complex hospitals, those 1A sites, met the adoption benchmark. Compare that to 48% of the hospitals with lower complexity scores.
Almost half of the less complex ones versus almost none of the most complex. That's stark.
It really is. And the interview suggested why. Higher complexity often just meant too many competing priorities. Teams were stretched thin, making it hard to add something new, even if it was good.
Makes sense. What else stood out?
Resources. No big surprise here, maybe, but it was clear. 43% of the hospitals that got specific resources for Stride adopted it,
Okay.
compared to only 29% of those that didn't get extra resources. That direct support was definitely a significant driver.
So money and staffing help. Shocker.
Yeah. Sometimes the obvious things are true. And the third big one was prior experience. Remember we talked about whether they'd implemented EBPs before?
Did that matter?
Absolutely critical.
Yeah.
35% of hospitals with at least some prior experience adopted Stride, compared to 0%. None of the sites with very little or no prior experience hit the benchmark.
0. That's
Done.
definitive.
It really is. And the interviews back this up. Sites with previous positive experiences just seemed more committed, more confident they could handle a new program like Stride.
So complexity, resources, and experience seem like the big 3 from the numbers. What about the qualitative side, the interviews? Did they highlight any major barriers?
Oh, definitely. The single most notable barrier that came up again and again was staffing. Challenges finding staff, delays in hiring. It was a huge bottleneck.
Staffing, okay.
All right.
Always seems to come back to that in healthcare.
It really does. Get this. 8 of the 24 hospitals that didn't meet the benchmark actually said they intentionally delayed even starting Stride because they just couldn't get the staff lined up.
Wow. So they couldn't even get off the starting blocks.
Pretty much. And conversely, the sites that did adopt often mentioned having adequate staff as a key reason they could make it work. It's just fundamental.
Okay, so we've covered the big drivers.
Mm.
Complexity, resources, experience, staffing. What about those other factors, the softer ones? Organizational readiness, resilience, climate. Did they matter as much as maybe we'd expect?
Yeah, this is where things get really interesting and maybe challenge some common wisdom in implementation science.
How so?
Take organizational readiness to change. The adopters did report slightly higher readiness scores on average, sure, but the researchers noted the difference was small. They said it was unclear if it was a big enough difference to be truly meaningful.
So maybe not the magic bullet people sometimes think it is.
Perhaps not in this context, or maybe the measures aren't capturing it perfectly. Same story for organizational resilience.
Okay.
A small difference between adopters and non-adopters, but again, unclear if it was really significant.
Okay. What about implementation climate? Things like support, recognition? That sounds important.
You'd think so, right? But this was maybe the most surprising finding. There was no consistent association between the implementation climate scores and whether a hospital met the adoption benchmark.
Really? No consistent link. That is unexpected. Lots of research points to climate being important.
Exactly. It was unexpected.
Yeah.
And it really makes you question, how well are we actually measuring these contextual factors? Or maybe for a program like Stride, other things just mattered more. It's a big question.
So more abstract, validated measures didn't pack as much punch as the more concrete things like resources or complexity. Did any other factors show some link, even if weaker?
Yeah, a couple of others showed small correlations. Hospitals that had longer average patient stays, Slightly higher adoption, 36% versus 23% for those with shorter stays, maybe more perceived need.
Maybe.
And patient satisfaction, the overall hospital rating. Adopters had slightly higher average scores, 76 versus 70 for non-adopters. So some faint signals there,
Yeah.
but nothing like the big three.
Okay, so pulling this all together, what's the big takeaway message here about context and getting good programs into practice?
I think the study really highlights just how hard it is to pin down and measure the specific contextual factors that genuinely drive implementation success, even though we all kind of know context is crucial.
Right.
It seems like, in this case at least, what might seem like sophisticated measures of, say, readiness or climate just didn't predict adoption as well as the more straightforward, maybe even crude, realities of resource allocation or staffing levels or just sheer institutional complexity.
That has huge practical implications, doesn't it? It suggests maybe we could simplify how we assess readiness for implementation.
Exactly. Maybe focusing on those easier to measure but potentially more impactful factors like resource availability or prior EBP experience could be more efficient. It could streamline things for future projects, reduce the measurement burden.
Makes sense.
And thinking bigger, this feeds into initiatives like age-friendly health systems or really any effort to implement evidence-based practices. It emphasizes that fit is key. The program has to fit the organization's context.
Fit, right.
And it suggests that maybe we need to bring the implementation science folks, the how-to experts, together with the intervention developers much earlier on, right from the start.
So they can design programs that are built to fit the real world from day one.
Precisely. Designed for dissemination and implementation, not just for efficacy in a perfect trial setting. That could really boost the chances of success later on.
Now, we should be fair. Every study has limitations. What were some caveats here?
Sure. Well, one is that they often had only a few staff members responding to surveys from each hospital, which is common, but limits how representative those views might be.
Okay.
Also, Stride itself is described as pretty nimble, flexible, not too many rigid parts. That makes it easier to implement, but means these findings might not perfectly apply to more complex, demanding interventions.
Right. Context matters for the intervention type, too.
Exactly. And finally, this was all within the VA system. It's a unique, integrated system with national support, a shared electronic health record, things that might have helped Stride spread in ways that wouldn't happen as easily in other more fragmented healthcare landscapes.
Good points to keep in mind. Okay, so let's try to wrap up this deep dive. The big story from the Stride experience seems to be, well, maybe the basics matter most.
I think that's a fair summary.
Yeah.
When it came to actually getting Stride adopted, the clearest signals weren't always the complex organizational theories, but the practical stuff. Did they have the resources? Had they done this before? Did they have enough staff? Were they juggling too many other priorities due to complexity?
Yeah. Those factors really seem to move the needle more than things like measured readiness or climate, which was quite surprising.
It really was. And it leads to a final thought, maybe something for you, our listeners, to chew on. In this world where we're constantly bombarded with new ideas, new solutions, new evidence, how can you apply these insights about organizational context? Think about initiatives in your own world, maybe at work, maybe a community group. Are there seemingly crude but easily observable factors like resources, staffing, competing demands, past experiences that you might be overlooking, but which could actually be the most powerful predictors of whether something new will actually take root and succeed?